MASLD, Diagnosis, Staging, and Treatment. Welcome to eHIV Review.
Metabolic dysfunction-associated steatotic liver disease, or MASLD, is the most common liver disease in the world. It affects about 40% of people with HIV, and it can lead to liver fibrosis and cirrhosis. Understanding how to diagnose, stage, and treat MASLD is really important for any provider caring for people with HIV.
To help increase that understanding, we're joined today by Dr. Carol Wegermann, an assistant professor of medicine in the Division of Gastroenterology at the Duke University School of Medicine in Durham, North Carolina. For our guest disclosures and additional CME information, please go to our website, ehivreview.org, and select the Volume 11, Issue 2 link. I'm Bob Busker, Executive Producer of DKP Med's e-Literature Review video programs. Dr. Wegermann, thank you for joining us today.
Thanks for inviting me.
Our overall learning objective for today's program is to appraise the efficacy of diagnostic and treatment options for MASLD for people living with HIV. This first part of our conversation is focused on explaining the key elements of diagnosis and treatment for early-stage MASLD, fibrosis stage 0 to 1. So with that in mind, if you would please, Dr. Wegermann, start us out in the clinic.
You're seeing a 33-year-old man with well-controlled HIV who just moved to the area. He is taking bictegravir, emtricitabine, and tenofovir alafenamide, and his HIV RNA, based on labs he shows you on his phone, is undetectable. His medical history is notable for obesity and prediabetes. You repeat his labs in the clinic, and his hemoglobin A1C is 6.3%. His AST is 18, and ALT is 25. You are familiar with the European AIDS Clinical Society guidelines, which recommend evaluation for MASLD in any person with HIV who has a metabolic risk factor or elevated liver enzymes. Since this patient has both obesity and prediabetes, you order a liver ultrasound, which shows increased echogenicity consistent with MASLD. You are aware that MASLD is independently associated with a higher risk of cardiovascular events.
But his liver enzymes are normal. Are his metabolic risk factors, along with the ultrasound findings, enough to lead you to suspect MASLD?
Well, despite the normal liver enzymes, and it's important to note that up to half of people with HIV who have MASLD have normal liver enzymes, as did this patient, there are a couple conditions that this patient has that elevate his risk for MASLD. One is obesity, which elevates the risk 3 to 4 times above that of non-obese people. Prediabetes, which is associated with about 2 to 3 times higher risk of MASLD, and actually HIV itself, which is associated with a 1.5 to 2 times higher risk of MASLD. I also want to highlight that this provider did something really important in screening this patient for MASLD. MASLD, as I mentioned, is independently associated with cardiovascular events. Many people who have late-stage disease never knew that they had MASLD, so early diagnosis is key to intervening before the disease progresses. So this patient does meet criteria for MASLD, which is defined by abnormal fat deposition in the liver, which can be found on imaging or a liver biopsy, in the presence of at least one metabolic risk factor. This disease used to be called non-alcoholic fatty liver disease before 2023, but that didn't really capture why it occurs.
Interesting points, Doctor. And I can see how they add up to a high degree of confidence in the diagnosis of MASLD. What's next?
Fibrosis staging, or assessing for scarring in the liver, is a key next step for anyone diagnosed with MASLD. The extent of fibrosis in the liver is the number one determining factor for liver-related morbidity and mortality. And it also determines whether patients are eligible for FDA-approved medications or clinical trials. There's some data that people with HIV experience faster fibrosis progression than people without HIV, which makes fibrosis assessment even more important in this population. Many guidelines, including that of the American Association for the Study of Liver Diseases, recommend a staged approach to assessing for fibrosis once you diagnose MASLD. So basically, you start with a low-cost, highly sensitive test to identify people who are at high risk for liver fibrosis. The most commonly used test that we use in the clinic is the Fibrosis 4 or FIB-4 score, which is really easy to calculate. The components of the score are the patient's age, the AST, the ALT, and the platelet level. And many modern electronic health records can actually calculate it for you. That will tell you if this patient needs any further testing.
For the sake of our discussion, doctor, let's assume the patient's platelet countlet is 200 per liter. What does that tell you?
Based on that platelet count, the patient's FIB-4 score is 0.59, which is low.
Meaning?
Meaning, because the FIB-4 score is low, the patient likely has stage 0 to 1 fibrosis out of 4. So no further fibrosis testing is needed.
So for fibrosis stage 0 to 1, what treatments would you recommend for this patient?
Well, there aren't currently any FDA-approved medications for individuals with MASLD and stage 0 to 1 fibrosis. Most clinical trials to date have focused on individuals with stage 2 to 3 fibrosis because they have a higher risk of developing cirrhosis in the short to medium term. Both FDA-approved medications for MASLD, which are resmetirom and semaglutide, are approved for individuals with stage 2 to 3 fibrosis. So the mainstays of treatment for this patient, for someone with stage 0 to 1 fibrosis, are a structured exercise program with a goal of 150 minutes a week. Generally, I tell patients 30 minutes a day, 5 days a week. And a mix of aerobic and resistance exercise has the best data. In addition, we recommend a Mediterranean diet and limiting ultra-processed foods and those containing high fructose corn syrup.
A question, doctor. In your experience, how difficult has it been for your patients to stick to an exercise plan?
It can be really difficult. The one study that looked at a structured lifestyle modification plan for people with HIV who have MASLD did find a benefit. And so structure may be helpful for keeping people on track. I encourage my patients to find something they like to do. Everyone's different with what kind of exercise they actually enjoy. There's some data that exercising with friends or a group can help with accountability and help people continue to do exercise. And for patients who don't have a safe place to walk near their home or can't afford a gym membership, nowadays there are plenty of free classes online that can be streamed from a smartphone.
Exercise recommendations usually come with diet suggestions attached. You mentioned the Mediterranean diet. Talk to us a little more about that for this patient.
The Mediterranean diet probably has the best data in MASLD, and the data is more limited in people with HIV. But we know that high fructose corn syrup is particularly toxic to the liver, so avoiding that is really key for keeping the liver healthy. We encourage patients to avoid ultra-processed foods and refined carbohydrates, choose lean proteins like vegetarian proteins, fish or chicken, as opposed to red meat or pork, and to limit their portion sizes. And I will say it's very challenging to stick to a healthy diet too. I encourage my patients to meet with a dietitian in our clinic for advice on meal planning and grocery shopping. And I tell patients to start with small changes. For example, if they regularly drink soda, swapping out the soda for water, or trying fruit and yogurt with a little drizzle of honey instead of ice cream for dessert. It's really hard to overhaul your entire diet all at one time. So change can take time.
Change can take time. That's a point every individual who's ever tried any kind of weight loss diet would agree with. Okay, final question about this patient, Dr. Wegermann. Does he need to see a specialist?
I would say probably not for this patient. He doesn't qualify for any FDA-approved medications for MASLD, and right now there are very few clinical trials enrolling for stage 0 to 1 fibrosis. But seeing a gastroenterologist or hepatologist, a liver specialist, can provide additional guidance on lifestyle modifications and monitoring. If this patient is going to be primarily followed in infectious disease clinic, then the provider should calculate a FIB-4 score annually, which, as I mentioned, is embedded into many modern medical records. And if that value increases and becomes indeterminate, which for MASLD is over 1.30, additional testing should be pursued. But you don't need to remember the cutoffs. Online calculators like MD Calc and many medical records will give you the reference ranges and let you know what's considered indeterminate or high and needs further evaluation. I will say this is one area of controversy in hepatology, what to do with patients with early stage disease. There's an argument some of these patients are going to progress into a range of fibrosis where they'll be eligible for treatments or trials. And so some practices do continue to follow patients with early stage disease to make sure they can capture that opportunity. On the other hand, we like to focus on patients where we have a specific intervention to offer. And if most of what we're discussing in terms of lifestyle modifications is being reviewed by other providers in infectious disease or primary care, sometimes we feel that the distance traveled or the copay is not necessarily worth it for the patient. So every situation is different.
Well, thank you, Doctor. Our key learning focus for this part of our discussion is to explain the key elements of diagnosis and treatment for early stage MASLD, fibrosis stage 0 to 1. What are the most important insights you'd want our learners to take back to their practices?
The most important insights, I would say, are one, any person with HIV who has a metabolic risk factor, for example, obesity or elevated liver enzymes, should be evaluated for MASLD with a liver ultrasound. Fibrosis staging at the time of MASLD diagnosis is crucial for determining appropriate follow-up and treatment. FIB4 is an easy way to risk stratify for fibrosis. Diet should be Mediterranean, low in processed foods, and high fructose corn syrup. And there's no specific exercise regimen that's the best in MASLD treatment, but a goal of 150 minutes a week with a mix of aerobic and resistance training seems to be a reasonable strategy.
Nicely summarized, Doctor. And we'll return with Dr. Carol Wegermann from the Duke University School of Medicine in just a moment. Providing the best care for your patients takes more than identifying the most relevant information. It takes expert opinion and analysis of the data, combined with expert advice about how to most effectively put that information into practice. It takes the Johns Hopkins University School of Medicine e-literature reviews. Top experts in their specialties, selecting the most important peer-reviewed literature, analyzing the information, and explaining what it can mean to clinical practice. E-literature reviews, independent medical education, CME, certified by Johns Hopkins University School of Medicine, and presented without charge by DKB Med. Welcome back to today's eHIV review program. Our guest is Dr. Carol Wegermann, an assistant professor of medicine in the Division of Gastroenterology at the Duke University School of Medicine. The first case of today's discussion focused on explaining the key elements of diagnosis and treatment for early stage MASLD, fibrosis stage 0 to 1. Let's turn now to the second focus of our conversation, describing the reasonable evidence-based treatment options for people with HIV with MASLD and stage 2 to 3 fibrosis. So if you would please, doctor, take us back to the clinic with another patient.
Great. Well, now you're seeing a 36-year-old man with well-controlled HIV who has just moved to the area like your other patient. He is taking bictegravir, emtricitabine, and tenofovir alafenamide, and HIV RNA is undetectable based on labs he shows you on his phone. His medical history is notable for obesity with a body mass index of 40 kilograms per meter squared. You repeat labs in clinic today, and you find that his hemoglobin A1C is 6.6%, consistent with diabetes mellitus. His AST is 78 units per liter, and ALT is 55 units per liter. His platelets are 190 per liter. You order a liver ultrasound to screen for MASLD, which reveals increased echogenicity, consistent with hepatic steatosis. You tell the patient he has MASLD. You calculate a FIB4 score, which is 1.99, which is indeterminate. You send the patient for transient elastography, which shows a liver stiffness of 8.5 kilopascals, consistent with stage 2 fibrosis. The patient asks, "Can you prescribe me something for this fatty liver?"
The patient is asking for a prescription for his fatty liver. So let's talk about treatment options. What are they, and which would you consider appropriate for this patient?
Well, in this patient, you could consider semaglutide. He has obesity and type 2 diabetes. So even if insurance won't cover it for MASLD, you have other potential indications, especially the diabetes, which is more commonly covered by insurance. The same things that lead to people without HIV getting MASLD, like obesity, diabetes, hyperlipidemia, also contribute to MASLD in people with HIV. But people with HIV additionally have immune activation, which is chronic to a certain extent, and the effects of lifelong combinations of antiretrovirals and other immune and viral factors. So the things that work in people without HIV are less established or tested in people with HIV.
Well, talk to us, if you would, please, about the evidence showing that this weight loss and diabetes treatment agent has been effective for patients with both HIV and MASLD.
The basis of using semaglutide for MASLD in people with HIV really comes from the Slim Liver study. And that was an open label, single arm study that evaluated semaglutide 1 milligram weekly in 51 people with HIV who have MASLD. The inclusion criteria for Slim Liver were hepatic steatosis or abnormal fat in the liver, which they defined as at least 5% intrahepatic triglyceride content on an MRI, with proton density fat fraction or PDFF. And participants also had to have central adiposity, prediabetes or insulin resistance, and no excessive alcohol use or other chronic liver diseases. Every participant received semaglutide for 24 weeks, after which they repeated the MRI to assess the intrahepatic triglycerides. So you have to keep in mind that Slim Liver was a small open label study, and I try to be honest with my patients with HIV about the limitations of that data. But what they did see was a reduction in intrahepatic triglyceride content over the 24 weeks of treatment, as well as improvements in liver enzymes and hemoglobin A1C. And additionally, cardiovascular risk reduction is an important consideration for people with HIV who have MASLD because MASLD is independently associated with cardiovascular events. So for this patient, I would be more aggressive about treating him since he's young and he doesn't have other life-limiting comorbidities.
Interesting. Other possible treatment options. Would you consider vitamin E?
That would be a reasonable option here too, although with some significant caveats.
Well, tell us about those caveats, as well as the evidence supporting vitamin E as a treatment for MASLD.
Sure. There was one study looking at vitamin E in people with HIV, specifically with MASLD. It was a single center open label trial, only 27 participants. And after 24 weeks of treatment, they did see significant decreases in ALT, a reduction of about 26 units per liter, as well as CAP scores, which is how we measure fat content in the liver on transient elastography. The study did not look at FDA endpoints, which are resolution of inflammation on a liver biopsy or improvement in fibrosis. But as I mentioned, they did see reductions in hepatic steatosis. In the general population, people without HIV, the PIVENS trial, which was published in 2010, compared vitamin E or pioglitazone to placebo in patients with MASH but no diabetes. And that showed that vitamin E was associated with improvements in liver enzymes and steatosis or fat content, but not fibrosis. More recent studies have looked at vitamin E again. It's kind of come back into favor in the past few years. And similarly, there seem to be improvements in histology or liver biopsy findings, particularly for inflammation. But despite that, vitamin E really hasn't taken off in the liver world, even though it's cheap and over the counter. Because at the end of the day, as I mentioned, what really drives liver-related morbidity and mortality is fibrosis or scarring. And there's really no data that vitamin E improves fibrosis. And additionally, there are risks to vitamin E. It's associated with higher risk of bleeding, specifically hemorrhagic stroke. And there are a number of drug-drug interactions that you need to consider. So my overall feeling about vitamin E is you just need to make sure not to overpromise, and you have to have a very frank discussion about the risks of treatment. Most of us are not routinely prescribing it, but if I had a person with HIV who could not tolerate a GLP-1 receptor agonist or insurance wouldn't cover it, and you wanted to be more aggressive about treatment, for example, a younger patient with more significant fibrosis, I think it's worth a conversation.
Good point, doctor. Other vitamins or supplements. Is there anything your patients have been asking you about?
A lot of my patients ask me about milk thistle, which was studied in MASLD in the past and really was in fashion in the earlier 2000s. We don't recommend milk thistle because randomized trials really haven't demonstrated meaningful benefit in MASLD in people with or without HIV. And in the bigger picture, many herbal and supplement medications can cause drug-induced liver injury. And sometimes that's the medication or supplement itself. Sometimes it's harmful additives that make their way in during production, which is a lot less regulated than with FDA-approved drugs. So I really encourage all of my patients with chronic liver disease to just take what's prescribed or recommended by one of their medical providers.
Well, thank you, doctor. And one final question now about this patient. What about other pharmaceutical agents? Would you prescribe resmetirom?
Resmetirom, good question. So, resmetirom is a liver specific thyroid receptor beta agonist that is approved for MASH with stage 2 to 3 fibrosis. Resmetirom basically improves cholesterol metabolism and reduces fat production in the liver. I would not prescribe it for this patient specifically. Maestro NASH, which was the clinical trial that led to resmetirom's conditional approval from the FDA, actually excluded people with HIV. And as I mentioned earlier, MASLD in people with HIV shares some features with MASLD in people without HIV, but it's also distinct because of the effects of the virus and treatment. So at this point, we really can't assume safety or efficacy of resmetirom in people with HIV. There's no black box warning for HIV, so technically you could prescribe it, but it's really a data-free zone. And in very exciting news, there is a clinical trial of resmetirom in people with HIV who have MASH with stage 2 to 3 fibrosis that will start enrolling this year. So I'm hopeful that we will have more data to guide that decision in the next couple of years.
Very good. Well, thank you, doctor. Our key learning focus for this part of our discussion has been to describe the reasonable evidence-based treatment options for people with HIV with MASLD and stage 2 to 3 fibrosis. What are the key things our learners need to know?
All right. First, a Mediterranean diet and regular exercise should be recommended to anyone with MASLD, whether or not they are eligible for FDA-approved medications. Second, semaglutide is a reasonable emerging option for people with HIV who have MASH and stage 2 to 3 fibrosis based on Slim Liver, which was a small open label study in people with HIV. Third, resmetirom could be prescribed, but there's really no safety or efficacy data in people with HIV, so many practitioners are not using it in people with HIV at this point. Fourth, vitamin E may not affect fibrosis. Really, the data is in liver fat content, but it's fairly harmless as long as you consider the risk of bleeding, so it can be considered in select patients after a discussion of risks and benefits. And finally, providers caring for people with HIV should not hesitate to refer patients for specialty care. Even for early stage MASLD, we are happy to talk things over with your patients.
From the Department of Medicine at the Duke University School of Medicine, Dr. Carol Wegermann, thank you for sharing your knowledge and expertise with us in today's eHIV review program.
Thanks so much for having me.
For eHIV Review, I'm Bob Busker.